Today I'm going to be talking about a tricky clinical case. Okay, so this 55-year-old female presented to the emergency department with a history of hypertension. She came in essentially with syncope, and we weren't really sure what was going on. So the entire workup was, the entire slew of tests were performed. An EKG was done, which didn't really show much. Could be a possible left bundle branch block, which is just abnormal conduction in the left ventricle. Nuclear stress test was done, which is giving some medication and seeing the cardiac function. Is anything, is there any ischemia or anything like that? That was technically abnormal. So a left heart catheterization was done to see, angiography, but that was negative. An ultrasound echo was also done, which is essentially we're just doing an ultrasound of the heart, looking for functional, diastole, systole of the heart, making sure that its function is normal. So all in all, it was negative, and the patient was discharged home. 2 years later, she came back, and she had multiple episodes of syncope. She immediately stood up from a chair, and she collapsed and had multiple syncopal episodes on the way to the hospital. Again, an EKG was done, which showed, again, nonspecific findings, possible left bundle branch block. A CT head was done to rule out any intracranial pathology. Did she have a bleed? Did she have a tumor? Nothing. Cardiac echo, again, was done. Normal systolic function, normal diastolic function, valves were working normally. So then they called electrophysiology, and electrophysiology recommended cardiac MR for more structural anatomy. So here we have a couple of slices going from left to right. So we see a 4-chamber view, late gadolinium enhancement in the left ventricle, which is where my arrow is pointing to. And then we see there is a little bit of late gadolinium enhancement in the basal septum, which I'll get back to later. So we were focusing more on this. Oh, maybe she's having an acute infarct. Maybe that's what's leading to her symptoms. Then we go to this view, and we saw, wait, what is this guy? What's going on in the SVC? Why is there this mass surrounding the SVC? And then we see a 4-chamber view again, and we see another, this right atrial mass. And as we go on, hopefully so we got some perfusion images, and again, you can see this right atrial mass almost circumventing the entire SVC. Well, what could that be? Why is that there? And then we also see some more images here as we're kind of going down. It also involves a portion of the IVC. So people were confused. What could this be? Is this a thrombus? Is this a mass? Is this a Liebman-Sachs, like an SLE? Is it an immune-mediated disease? Is it a lymphoma? It could be like 1,000 different things, and the radiology report definitely had like 10 diagnoses. So CT chest was performed. They thought it could be metastatic disease. And interestingly, we saw something else which we weren't really expecting. We saw these guys. So we see these hypodensities that are surrounding the common carotid arteries bilaterally, and the diagnosis of vasculitis was made. So this patient's having vasculitis, but also has a cardiac mass. So how do we put that together? What does that exactly mean? So here we have some more images. So we're going through our CT. There's a coronal, and this is a really good example. I wish I could slow it down, but if you guys can focus in on this area, you'll see right there's a mass. Here there's a mass. And then same thing on the right image. You'll see the common carotids. You'll see these hypodensities involving both common, and right there the brachiocephalic. So pretty well-defined vasculitis in the neck and a pretty good-sized mass in her thorax in a young female with no history, no significant past medical history except hypertension. So what are we thinking? So this is our differential diagnosis. Erdheim-Chester disease, incredibly rare diagnosis. It's like a histiocytosis involvement. It usually involves a pericardium, so you get like a fusion. So it doesn't really present like this, so that maybe wasn't so likely. Was it a thrombus? The reason why we weren't thinking that it could be a thrombus was I didn't have an image, but the mass was enhancing. So we're like, okay, maybe it's not a thrombus. Is it metastatic disease? Well, it could be, but we didn't see any. She doesn't have any primary, and she has no other metastatic deposit. So again, it's unlikely. Abscess? There's no peripheral enhancement. Didn't really look like an abscess, so we thought, okay, that's probably not it. Lymphoma, I'm going to keep there because it could always be lymphoma, but that is a separate topic. And then is it SLE? So this is another autoimmune disease, but these classically involve the valve, so it wasn't that. So we were thinking, okay, maybe it's sarcoidosis. That was kind of on our differential. So how do we confirm this? So we needed a biopsy specimen. So they went in through a thoracic surgery, did what's called a video-assisted thoracic surgery, which is they put in like a scope into the thorax, and then they put in another scope, which is very minimally invasive, take a specimen from the right atrium, send it off to pathology. And here, I'm told from my pathology friends, are non-caseating granulomas, which is very classic for one type of disease. I mean, it's classic for many, like TB and other, but it's classic in her case with sarcoid. And so what's really interesting is, so the reason why I think this is such an interesting case is because, and Martin Prince kind of like told me a little bit about this before, is that we were essentially, like, there was a mass in this lady's heart. That's a bad diagnosis. But once you have a sarcoid, once you can get the diagnosis of sarcoid, it's very treatable. And that's what I kind of found as I was looking through the literature. Cardiac sarcoidosis is very responsive to high-dose steroids. And how do we see this sequentially? We actually imaged this lady with FDG PET every like 6 months or 4 months. And this is also a very interesting imaging modality. So normally our heart doesn't take up glucose, but when inflammatory cells, they usually take up glucose. So we see on this bottom right image, the left ventricle, this is all inflammatory, you can say, active sarcoid. You don't see it that much here, the right atrium, but there was also uptake in the right atrium. This is also really interesting because these patients, they have to have increased uptake, but they also have to have decreased perfusion. These are the two things that you have to see. So we see increased uptake in the left ventricle. Patients gets really high dose steroids. So 14 SVU, that's not good. It starts to go down to 4 SVU, and we see here, again, less uptake. This all looks diffuse because it's kind of mapping based on how high the parameters are set. And then again, 6 months later, 1.5 SVU. So essentially, she responded very well to both the vasculitis and the sarcoidosis. And we thought this was kind of interesting. I mean, she had no history of sarcoid. Sarcoid presents with lung involvement, skin involvement, joint involvement, or eyes. She presented with heart involvement. Cardiac sarcoidosis only involves 5% of people with sarcoid, so it's very rare. Vasculitis, again, we talked about this before. Vasculitis is very responsive to steroids, so it's a very good diagnosis for her. Interestingly, as I was going through the literature, there was 2 theories about how the vasculitis can happen in sarcoid. One of the theories is that, so it's an immune-mediated disease. You get these lymph nodes that get really big, and the lymph nodes cause extrinsic irritation of the vessels, and that could be one of the ways you get vasculitis. Another one was that it's internal inflammation. So you have all these toxic metabolites due to sarcoid that are floating around, and they start to damage the vessel, and that could be one of the ways. I just thought that was an interesting point to point out. Okay, and last slide. So just want to touch base on what are some of the findings we see on cardiac sarcoidosis. So again, it's a subclinical involvement in up to 25 to 70%. That's a huge range. So people who have sarcoid could be walking around, they could have cardiac involvement, but they would never know. And I think that that's an interesting point because there's definitely some role of imaging to play there. Cardiac MR, what are some of the things we see? We see basal septal involvement, which we did see on that first image, which we see also here. It's usually very subtle, and it's usually, again, asymptomatic. But then, as it starts to progress, you can start to get heart block, and that's what she ended up started getting. She probably had an abnormal conduction system, had syncope, and subsequently she actually had a pacemaker, and she's doing a lot better. But in severe cases, it can involve the ventricle, the wall of the ventricle, the basal septum, and then in really severe cases, you can get heart block, heart failure, and ventricular tachycardia. I think it's important, again, to note that they point out that sarcoidosis, one of the main ways of telling the prognostic indicator is how much of the left ventricle is involved. I thought that was interesting. Basal septum, usually asymptomatic, very responsive to steroids, so we want to catch those things early. And these are some of the references I had, and